Hello everyone and welcome to our module on sleep disorders. Before we can talk about sleep disorders, we need to talk a little bit about normal sleep physiology. So when you sleep, you progress through several stages of sleep. There are 3 non-REM stages, N1, N2, and N3, and then there is REM, which is rapid eye movement sleep, and we'll talk about all of these in the next few slides. Each stage of sleep has unique EEG findings if you have a person sleep while they're being monitored by EEG. So by way of review, an EEG is an electroencephalogram. This is a patient hooked up to an EEG machine. And when you are hooked up to this, you can record the brainwave activity as is shown over here. That's called an EEG. So if you do this to someone and then you have them sleep, you can record the unique EEG findings that occur during each of the phases of sleep. So when you get into bed and you're about to go to sleep, but you're still awake and your eyes are open, what you will see on EEG are what's known as beta waves. Beta waves have a low amplitude and a high frequency, and this is an example of beta waves shown on the screen here. When you close your eyes to start to get ready to go to sleep, your EEG shifts to what are known as alpha waves. This is a picture of alpha waves here. You can see that they have a higher amplitude, meaning that they are bigger waves compared to the beta waves, and they are more synchronous, meaning they are more organized compared to the disorganized pattern of beta waves. Then once you fall asleep, you enter the stages of non-REM sleep, and the first one is called N1. In N1, what you see on the EEG are theta waves. Theta waves are waves that vary in frequency and amplitude, as shown in this example on the screen. And N1 is the lightest stage of sleep. It's where it's easiest to wake a person, and it's also the smallest percentage of total sleep time. You spend only about 5 to 10% of the time when you're asleep in N1. After N1, N2 occurs, and in N2 there are also theta waves just like N1, but what defines N2 is that things start to appear in the EEG called K-complexes and sleep spindles. If you look at the bottom right side of the screen, this is a K-complex. It's a sudden spike in the amplitude of the waves on the EEG. A sleep spindle is a sudden increase in frequency of the waves. It's a bunch of waves close together. So what happens at N2 is you start to see these K-complexes and sleep spindles, and that's how you know that you've entered N2. N2 is the largest percentage of total sleep time. About half of our sleep time is spent in N2. And this is the stage where people who grind their teeth when they sleep will do so. That's called bruxism. The next stage of sleep is N3. This is the last phase before REM sleep. And the hallmark of N3 on the EEG is the presence of delta waves, which are also called slow waves. Of all the EEG waves seen in sleep, these waves have the lowest frequency and the highest amplitude. This is a picture of delta waves or slow waves at the bottom of the screen. N3 is the deepest stage of sleep. It's when it's hardest to waken the sleeper, and this is the stage where things like sleepwalking, sleep talking, and bedwetting occur. We'll talk more about this later on. And then finally, you enter REM sleep. REM stands for rapid eye movements, and it gets its name because during this phase of sleep, your eyes bounce back and forth. The part of the brain that coordinates this is the PPRF. This is the paramedian pontine reticular formation. And in the neurology section, in some of the eye movement disorder videos, I talk about how this portion of the brain helps you coordinate movements so that when you look left, both eyes go to the left, or when you look right, both eyes go to the right. So if you know that, it's easy to remember that the PPRF is also the section of the brain that coordinates the back and forth rapid eye movements. On EEG, what you see during REM sleep is a low voltage pattern. It often looks sawtoothed, and this is an example of what REM sleep looks like on the EEG on the screen here. During REM sleep, there is a loss of motor tone. Your muscles become paralyzed, and if you know this, it's easier to understand why you would never sleepwalk or wake up and scream out during the night during REM sleep because you're paralyzed. Those things happen during N3 when your muscles are not paralyzed, but you're in your deepest stage of sleep. What does happen in REM sleep is this is when you dream and when you can have nightmares. This is also when men will sometimes develop an erection during the night. This is called penile tumescence. So those are the stages of sleep, but what you need to understand is that during the night you go through multiple cycles that involve all the stages of sleep. So you'll go through NREM sleep and REM sleep and then back to NREM sleep and then back to REM over and over again during the night. It's repeated during the night. And one cycle through NREM and REM takes about 90 minutes, and you'll go through multiple of these 90-minute cycles during the course of the night. And as each of the cycles progresses through the night, the length of REM time increases and the length of N3 time decreases. This is easier to understand if we look at a normal hypnogram. So a hypnogram is a graphical representation of the amount of time a person spends in each stage of sleep, and shown on the screen is an example of a normal hypnogram. So as you can see, during the course of the night, a person goes through multiple cycles, and each cycle is about 90 minutes of time. So let's look at the first cycle. The person starts off in the awake stage, obviously, and then spends a little bit of time in N1, N2, and then finally N3. The person then goes back through the N stages and has a little bit of REM sleep. Notice that during each cycle, the amount of N3 time gets less and less. Notice also that during each cycle, the amount of REM time gets more and more. So that's normal sleep physiology. More REM time as you progress through cycles and less N3 time. Notice also that among all the stages, the most time total is spent in N2. If you sum up all these times that the person spends in N2, that's about 50% of your sleep time. And that's why, as I told you before, N2 is where you spend the most time during the course of the night. So these are all normal features of normal sleep physiology, but they're the kind of thing they'll ask you about on your board exam. There are a number of classes of drugs that can alter certain aspects of sleep physiology. It's often said that these drug classes affect sleep architecture. In particular, sedative drugs can decrease the percentage of time that is spent during sleep in N3 and REM. Alcohol will do this, benzodiazepines will do this, and I've bolded benzodiazepines because we'll talk later about how this class of drugs is used to treat some sleep disorders, and barbiturates can also have this effect. For some patients with sleeping problems, a class of drug is often prescribed called non-benzodiazepine hypnotics. Drugs in this class include zolpidem, zaloplan, and azopiclone, and what these drugs do is they activate the benzodiazepine GABA receptor, but they are not benzodiazepines. They have a very high affinity for a subtype of the benzodiazepine receptor called the BZ1 receptor, and the effect they have that helps some people with insomnia is they decrease the amount of time it takes to fall asleep. This is called sleep latency, but they have much less effect on the sleep cycle than benzodiazepines, so there isn't much impact on N3 and REM sleep. In the video on mood disorders, I talk in detail about depression, and it's high yield to know that depression has a number of effects on sleep physiology. First of all, patients who are depressed have REM sleep that starts quicker after sleep onset. This is described in your textbooks as a fall in the REM latency time. There's also an increase in total REM sleep time among patients who are depressed and a decrease in the slow wave or N3 sleep time. And interestingly, if these patients are treated with antidepressant drugs and they start to feel better, their sleep rhythms go back to normal. Now we're going to talk about sleep disorders, and we'll start by talking about parasomnias. Parasomnias are disorders that occur during sleep. They're either undesirable physical events like movements or behaviors or unwanted experiences like emotions or dreams. And parasomnias are subdivided into those that are NREM related, meaning they don't occur during REM sleep, and those that are REM related. REM-related sleep disorders that are parasomnias include sleep paralysis. This is where patients wake up, but they cannot move. And remember, if the patient cannot move during sleep, that likely involves REM sleep because that's when your muscles are paralyzed. In addition, nightmare disorders also occur during REM sleep, as I mentioned earlier. NREM parasomnia disorders are disorders of arousal during sleep. And remember, these aren't going to happen during REM sleep. In REM sleep, you're paralyzed, so you're not going to have an arousal problem. This is only going to occur during NREM sleep when your muscles are not paralyzed. These usually occur during N3 because, as I told you before, that is your deepest phase of non-REM sleep. In addition, they usually occur earlier in the night, and that should make sense to you because, as we saw on that hypnogram, there's more N3 sleep earlier in the night. Patients with these disorders do not recall the arousal activities. They're often uncovered by things they see when they wake up the next morning or by family or friends that live in the same house. So these include things like sleepwalking, sleep terrors where patients sit up and scream, or sleep-related eating disorders. I once took care of a patient who used to wake up during the night and cook herself a meal, and the next morning she would have no memory of that, but she would find the kitchen full of dirty dishes, and that's the way she knew she had a sleep-related disorder. And the treatment for these problems is benzodiazepines because, as I told you earlier, they decrease the amount of N3 sleep. For the rest of this video, we'll talk about narcolepsy, which is the classic sleep disorder. Narcolepsy you can think of as a neurologic disorder that involves abnormal sleep-wake cycles. Patients sleep during wakefulness and they're awake when they should be asleep. Patients who have this disorder often complain of excessive daytime sleepiness, and we'll talk more about that later. This disorder is associated with and believed to be caused by decreased levels of neuropeptides coming from the lateral hypothalamus. The two neuropeptides that have been implicated are one called orexin A, it's also called hypocretin 1, and another one called orexin B, which is also called hypocretin 2. And very rarely, usually in research circumstances, the cerebrospinal fluid can be tested to make a diagnosis of narcolepsy by identifying the level of orexin A, otherwise known as hypocretin 1. Patients with narcolepsy have daytime sleepiness. They often fall asleep during the day at inappropriate times. Sometimes they have sleep attacks where they suddenly fall asleep and start dozing. Importantly, these patients are not tired when they wake in the morning, and I've bolded this. If you see a patient who has daytime sleepiness, the first thing you should think of is sleep apnea because it's much more common than narcolepsy. But patients with sleep apnea wake up in the morning and feel exhausted. They have not gotten a good night's sleep. Patients with narcolepsy wake up in the morning and feel normal. However, later during the day, they suddenly become sleepy. Another feature of narcolepsy that is sometimes seen is called cataplexy. This is a sudden loss of muscle tone. It usually affects the face, neck, or knees. Basically, it's like the patient going into REM sleep suddenly during the day where they lose their muscle tone just like you do during REM sleep. The muscles can become weak and it can sometimes lead to collapse. However, there's no loss of consciousness. That makes it different from syncope. When patients have syncope, they lose consciousness. In cataplexy, patients just suddenly fall to the ground and are still fully conscious. This is classically triggered by strong emotions. Classically, it's laughter or excitement, but sometimes it's anger or grief. So a patient with narcolepsy who is at a party and hears a funny joke and starts cracking up will suddenly fall to the ground with a loss of muscle tone. That is cataplexy. Patients with narcolepsy sometimes have hallucinations when they are falling asleep or when they wake from sleep. These can be multiple different kinds of hallucinations. They can be visual, tactile, or auditory. Usually the type of hallucinations seen in narcolepsy are called hypnagogic. This means they occur when they're falling asleep. Rarely they can be hypnopompic. These are hallucinations that occur when awakening. So what will happen is the patient will complain that every night when he or she is trying to fall asleep, they begin seeing things or hearing voices. Those are hypnagogic hallucinations, and that's what's seen in patients with narcolepsy. Sleep paralysis can also be a feature of narcolepsy. Sleep paralysis is the inability to move after awakening for about 2 minutes. This is caused by REM sleep features occurring in the brain while the patient is awake. Remember that you have limited movement during REM sleep, so if you wake up and you're still behaving in terms of your brain like you're in REM, then you won't be able to move. This also sometimes occurs just before falling asleep, and it can occur together with a hallucination, which is very frightening for the patient. You can imagine that if you wake from sleep, you cannot move, and you are hallucinating, meaning you are seeing or hearing things that aren't there, you will be terrified, and that's one of the presenting complaints in some patients with narcolepsy. Narcolepsy usually presents at a young age in the teens or early 20s. It occurs in men just as much as in women, and it's usually sporadic, meaning it doesn't run in families. There are rare cases of familial narcolepsy. And we don't know exactly what causes this, but there is what's called the autoimmune hypothesis, which states that orexin neurons are killed by some autoimmune process. And the reason for this hypothesis is because narcolepsy is strongly associated with the HLA subtype DQB1, and it's high yield to remember that. So because it's associated with this HLA type, many people hypothesize that there's an autoimmune underlying etiology. There are a couple of drug therapies used to treat narcolepsy. Most of these are stimulants to help people stay awake during the day. First one is modafinil. Modafinil is a mild stimulant. It's potentially addictive, so it's considered a controlled substance. It promotes wakefulness through a poorly understood mechanism, but it's been shown to have effects on multiple systems in the central nervous system, including dopamine, norepinephrine, and GABA. Other stimulants are also used in narcolepsy to help people stay awake during the day. These include drugs like methylphenidate and amphetamines. Both of these drugs are indirect sympathomimetics, so what they do is they increase levels of dopamine and norepinephrine in the synapses of the central nervous system. And you may know that these two drugs are also used in ADHD. Methylphenidate is known as Ritalin, and amphetamines are known as Adderall. The last treatment we'll talk about is a drug called sodium oxybate. Sodium oxybate is the salt of a substance called gamma hydroxybutyrate, or GHB. GHB is a GABA metabolite. Its mechanism of action is not known, but it is a CNS depressant. You can think of it as similar to an anesthetic. The biggest benefit of this drug is that it reduces episodes of cataplexy, but it also improves nighttime sleep and daytime sleepiness. So this affects all the elements of narcolepsy for patients with this disorder. Now, this drug has a checkered past because an illegal version of GHB has been used as a date rape drug. That's because it's a sedative. So this is a controlled substance just like modafinil. The way patients take this drug is complicated. It's given as a liquid at bedtime, and then patients have to wake about 3 to 4 hours later to take another dose. They often have to set their alarm, although over time they learn to wake on their own. So this is a complicated process to take this drug, but many patients with narcolepsy are willing to go through it because it's effective for multiple features of the disorder, including the cataplexy attacks, which can be very embarrassing and disabling. And that concludes our video on sleep disorders.